Now, the first thing we need to do, as in any joint, is look at observation. And when we're observing for TMJ dysfunction, we want to observe the whole face. So among some of the things we'll see is evidence of trigeminal facilitation. Now, if you remember your anatomy, the TMJ and the muscles of mastication are all innervated by the trigeminal nerve, as is the skin on the face. If this nerve is facilitated, it basically looks as if everything is drawn to the ear on that side. So you'll see the eyeball looks distant when you look at it. The lips look pulled this way. The nose may look a bit pulled this way. Deviation of the jaw may come this way if it is trigeminal, but depending on the dysfunction, it may actually be deviated because of the mechanical impact that the dysfunction is having. So we can observe static position. More importantly, though, we want to observe dynamic movements, particularly opening and closing. So if we have the patient open their mouth as wide as he can and close, the maximum amount of opening would normally be about 2.5 of their knuckles through there. So they shouldn't be able to fit more than that into their mouth easily. If they're opening a lot more than that, then they're probably hypermobile, possibly unstable. Much less than that, and they're hypomobile. So we need to look at the range of the movement. In addition, as they open, we need to look at the quality of the movement. Do they open straight up or do they deviate? Now, if they deviate, they'll tend to deviate to the less mobile of the two sides. Now, that may be because that side's hypomobile, or it may be because that side's normal and the other side is hypermobile. If it's due to hypomobility, you'll generally see them deviate fairly early in the range. If it's hypermobility, they'll deviate near the end of the range. Okay? So look for that. In addition to straight deviations, you may see an arc form. So they'll open, deviate, and then correct when they get to the bottom. Now, this can be due to muscle imbalances. So they've got some, usually again, masticator muscle tightness that will limit the opening part of the movement, but as they keep on forcing it open, they can stretch through it. Or it may be due to a meniscal displacement that blocks the joint temporarily, makes it hypomobile, and then basically replaces itself and allows the opening to continue on. In that case, what you'll see is an accompanying click as it deviates. So we need to look for the quality of the movement as well as the range of the movement. The other thing that's important to ask the patient is at the end of the opening, open for me again, and when they're as wide as they can possibly be, force it open. Now, a person with an instability will naturally limit their opening to where they know it's going to become unstable. By you asking them to force it open, they'll hit that unstable area, and you may actually look, it really looks as if the jaw is going to fall out of the head, and it just sort of clunks forward. And then to get it closed again, they have to clunk it back, and it's actually an effort of will to overcome that first resistance to closing. So we need to look at that.